Hi, all of you. Now this is the third video. We are going to discuss here the third layout, that is peripheral vascular disease and gangrene. And again there are 5 questions. The questions are: what is gas gangrene? How the patient of gas gangrene presents to us? Who are at maximum risk to develop gas gangrene? Enumerate the organisms and toxins involved in gas gangrene. And the question could be, what is the role of hyperbaric oxygen therapy in gas gangrene? You can also have a short note regarding hyperbaric oxygen therapy. That's all. So important for your theory as well as viva, practical examination. And the first question is, what is gas gangrene? The gas gangrene, basically just remember one family of bacteria, that is Clostridium, and that's why this gas gangrene is also known as Clostridial myonecrosis, right? There is presence of gas and there is pus formation, and whenever the body tissue is invaded by anaerobic bacteria, this is the condition. And these anaerobic bacteria, they can live in low oxygen content, right? Then how the patient of gas gangrene presents to us? A brown, red or bloody discharge may be there, may be oozing from the affected tissues, and this gas is produced by Clostridium, and whenever there is a gas, we can have a crepitus there. While examining the patient, there is crackling sensation. When the affected area is pressed, it becomes swollen and blisters may develop at the site, and usually the person suffering from gas gangrene may present to us with severe pain, with fever, tachycardia and tachypnea. The question is, who are at maximum risk to develop gas gangrene? The two important group of population, the immunocompromised patients at risk to develop gas gangrene, and the patient who is having local tissue hypoxia. And the person having local tissue hypoxia as well as he or she is immunocompromised, they are the most at risk to develop gas gangrene. And why there is local tissue hypoxia? It could be due to trauma or peripheral vascular disease, the Berger's or Raynaud's, right? And the most common organisms responsible for this gas gangrene condition is Clostridium perfringens, the Clostridium septicum, and Clostridium histolyticum. So these 3 bacteria, they are very commonly seen. There is another, the 4th one. Very soon we will discuss that also. Another question could be, enumerate the organisms and various toxins that is involved in gas gangrene. Very important topic regarding the viva as well as the entrance exam. The Clostridium septicum, it is the most common cause of a spontaneous gas gangrene associated with gastrointestinal abnormalities. For example, a patient of colonic cancer during resection or in the post-operative period, or if ill-managed, may develop this gas gangrene because of Clostridium septicum. Whereas in post-traumatic infections of gas gangrene to Clostridium perfringens and Histolyticum. These are the two species of bacteria we commonly come across in post-traumatic infections. In GI conditions, Clostridium septicum is important. And this is the fourth member, the Clostridium sordelli. Recently, a very fatal pathogen, although uncommon, it causes fatal shock syndrome, very dangerous condition, and gas gangrene of the uterus, especially after medical abortion with oral mifepristone and misoprostol, that is intravaginally misoprostol. This Clostridium sordelli is associated with medical abortion in females. And there is uterine gangrene. The uterus is gangrenous. Second group of population where this Clostridium sordelli is important is the IV drug abusers of heroin injections who are taking heroin injection, and this term is more commonly referred to as popping, right? So two group of peoples, the medical abortion associated with uterus, the gangrenous uterus, with drugs, oral mifepristone and misoprostol, and the second population, the IV drug abusers, right? Clostridium sordelli. These patients may develop gas gangrene. Even with the best of care, and what are the points in best of care? The early recognition of the condition, the surgical debridement, extensive debridement, the broad spectrum antibiotic coverage, as well as the hyperbaric oxygen therapy. The mortality rate is around 20 to 30%, right? And if simultaneously this hyperbaric oxygen therapy, if we can give to the patient, yes, recently this mortality can be brought down up to 5 to 10%. But if we are not treating the patient, or if the patient is not receiving any treatment for that, disease has a fatality rate of almost 100%, right? Now, when to suspect gas gangrene in any patient who is presenting to us with ischemia or the features of the signs of gangrene? The answer is suspect gas gangrene if anaerobic gram-positive bacilli are present in a wound with necrosis of or involvement of soft tissue as well as the muscle, right? And organisms, if they are producing a gas identifiable on X-ray or CT scans, there is higher chance or higher possibility that we are having a patient who is suffering from gas gangrene, and accordingly we must take the decision quickly. Here you can see an X-ray showing a patient, the bilateral thighs, a patient of gas gangrene. You can see the black spots, the subcutaneous spaces everywhere, here in this area. This patient was a young patient, around 30-year-old, post-traumatic, and this is how on X-ray a gas gangrene is usually visible, right? So clostridial organisms, they produce alpha and theta toxins. They produce other toxins also, but alpha and theta toxins, they cause extensive tissue damage, and infection can spread very quickly within a matter of hours only, and finally the patient may develop shock, sepsis, and yes, if not treated, death also. And the tissue, whenever it is better oxygenated with around, let's say, 70 millimeter of mercury oxygen tension, the tissue will inhibit the organism growth as Clostridial species are facultative anaerobes. So high oxygen tension is always negative for the bacteria and good for the patient. So we must maintain a high oxygen tension there. What is a facultative anaerobe? Basically, a facultative anaerobe is an organism that makes ATP by aerobic respiration if oxygen is present, but can switch over to fermentation process if oxygen is insufficient or absent. So Clostridium species, the various Clostridia, they are facultative anaerobe. They can make ATP aerobically as well as anaerobically whenever oxygen is not present. And remember, if oxygen tension of tissue is less than 30 millimeter of mercury, then the Clostridial organisms, they will grow more quickly. And here is the point where hyperbaric oxygen therapy is working as a management point, as a management part. In the management part, the hyperbaric oxygen therapy is very effective, right? Infection can develop slowly over weeks or sometimes rapidly, within hours, depending on the oxygen tension of tissue and the amount of organism inoculated there. As far as the virulence of organism is concerned, it depends on the various exotoxins produced. The Clostridium perfringens, remember this bacteria, this Clostridium perfringens is the most pathologic organism in gas gangrene with 17 known toxins. 17 known toxins are there. And out of these 17 known toxins, the most toxic being the alpha toxin, also known as it's a type of lecithinase, right? Alpha toxin, most toxic. The alpha toxin is a phospholipase lecithinase that breaks down cell membranes and it triggers the platelet aggregation, thrombosis, and histamine release. Again, this platelet aggregation and thrombosis leads to vascular compromise. Again, it adds on to the formation of gangrene. Other toxins are collagenase, hyaluronidase, hemagglutinins, and hemolysins. Apart from this alpha toxins, that there is theta toxin. It causes direct vascular injury and breakdown of leukocytes, causing impaired host inflammatory response to the infection. And this collagenase breaks down the connective tissue and it helps in the rapid spread of organism across the tissue planes, and that is why the patients of gas gangrene, there is fast spread of infection in the subcutaneous plane and the various facial planes, and in this manner it can also involve the deeper layers including the muscles. These are the main reasons that it can easily cross over the connective tissue planes, right? So for managing these type of patients, we should not waste our time and we should act accordingly very fast. So what are the common toxins produced by Clostridium family? The common toxins produced by Clostridium perfringens, very important topic for entrance. This alpha toxin I have already discussed. This also known as lecithinase or phospholipase. It breaks down cell membrane leading to cell death. It's a hemolytic toxin and cardiotoxic also, and the most dangerous toxin produced by Clostridium perfringens, most dangerous for the patient, alpha toxin. Then beta toxin causes necrosis of tissue, delta, epsilon. Again, delta toxin is hemolysin, hemolytic activity responsibility is there. Then epsilon toxin, it acts to increase cell membrane permeability. An enzyme is there, permease. Then Iota toxin, again it causes necrosis of tissue. So there are basically 4 toxins causing necrosis of tissue. First one was this beta toxin, then Iota toxin, kappa and nu toxin, and 4 are hemolytic, the alpha, delta, and nu and phi toxin. These are hemolysin. So just to enumerate these toxins, the important thing is you may have an objective question: which one of the following is not a toxin produced by Clostridium family in a gas gangrene patient, and like that, right? What are the signs of severe sepsis in gas gangrene patients? Septic shock, adult respiratory distress syndrome, DIC, finally leading to hemolysis or hemolytic anemia. This could be the presentation of patient whenever there is severe sepsis in the patient of gas gangrene. Remember, any patient with a cellulitis infection who develops additional signs of crepitus secondary to gas in the tissue and necrotic or dusky looking skin, these type of patients should be evaluated for gas gangrene. As far as the management is concerned, the early IV antibiotics with early surgical debridement followed by hyperbaric oxygen therapy can save the patient sometimes, and intravenous antibiotics and early surgical debridement, it reduces the mortality rate to about 30%, and if we are adding hyperbaric oxygen therapy to this management, this fatality rate can be reduced down to 5% sometimes. The drugs, the penicillin group or third generation cephalosporins, and plus clindamycin. Clindamycin is important here. It should be added because this combination will also treat group A streptococcal necrotizing fasciitis part. Clindamycin should be strongly considered in patients of gas gangrene because it inhibits the synthesis of clostridial exotoxin, as well as it is going to lessen the systemic effects of toxins produced by Clostridium family. Now finally, the last question in this layout, the third layout: what is the role of hyperbaric oxygen therapy in gas gangrene? Hyperbaric oxygen therapy, basically this is going to help the patient in various ways. For example, it halts the exotoxin production by the bacteria. It improves the bactericidal effect of the antibiotic. Due to high tension of oxygen, this is going to treat the tissue ischemia. It improves the reperfusion injury of the tissue, and high oxygen tension promotes the activation and migration of stem cells and phagocytosis. Then it induces vasoconstriction, and this vasoconstriction reduces the tissue edema, but due to high oxygen tension, hyperbaric oxygen therapy, it is going to increase the oxygenation of tissue. So in these different ways, this hyperbaric oxygen therapy is useful for the patient of gas gangrene. So oxygen tension of tissue increases by a factor of almost 1000, and this increased oxygen is going to help in resolving the hypoxia. It improves the cellular activity, it inhibits the bacterial growth, and it affects the cytokinesis. And this cytokinesis increases the migration of neutrophils to injured tissue, again increase phagocytosis and control of the disease. In addition to this, the hyperbaric oxygen, it also increases the production of growth factors. Which growth factor? Vascular epidermal growth factor, right? It induces neovascularization and tissue repair with capillary budding. So again, it is going to treat the patient. And how this VEGF is acting or not, how can we assess it? This is recognized clinically as increased granulation tissue formation. And this increased granulation tissue formation is usually seen after few settings of hyperbaric oxygen treatments, right? So that was all in layout 3. In layout 4, these are the questions we are going to discuss. What is Fournier's gangrene? What are the pathogens involved in Fournier's gangrene? Enumerate some other types of gangrene if you can. And what is Melanie's gangrene? And what are the key points in management of gangrene? These questions we'll discuss in 4th layout. So thank you. Let's meet there. Till then, bye-bye.